Hi, my name is Laura Bonneville, and I am with Heritage Health. And today myself and Jennifer Romero are going to be giving a presentation on evaluating and developing multidisciplinary care teams for substance use treatment. I'm a behavioral health consultant. I'm a licensed professional counselor, and my role is in the medical clinic. I work directly with our primary care providers. So when patients come in to see their primary care provider and they have either an emotional health complaint or are struggling with addiction, a provider will choose to get me involved in care. I'll go into the exam room and I'll deliver some interventions myself or connect them with other services, oftentimes both of those things. When it comes to patients that come into the exam room that have a substance use issue, then I'm going to refer them to our substance use treatment offices at Heritage Health called Restored Paths. And then I also might connect them with other resources, funding resources, and maybe screen them to see if they're appropriate for our medication assistance treatment or therapy, if their provider has not already done that. So this presentation is broken into two sections. I'm going to be presenting on the first section, which is evaluating multidisciplinary care teams for substance use disorder or treatment. The purpose of this section is to provide training participants with evidence on the use of multidisciplinary teams when treating substance use disorders or opiate addiction, which you're going to hear about specifically in this presentation. Participants will learn key terms used in the treatment of substance use disorders. They'll hear about the different models used in the coordination of treatment of substance use disorders and best practices that produce the most effective outcomes. So these key terms are just to try to get us on the same page when it comes to understanding this topic and the content of this presentation. So the first key term I'm going to talk about is evidence-based. Simply put, this is a process used to review, analyze, and translate the latest scientific evidence. The goal is to quickly incorporate the best available research along with clinical experience and patient preference into clinical practice. Best practice are generally accepted standardized techniques, methods or processes based on evidence that have proven themselves over time in order to obtain improved patient and health outcomes. The term co-occurring means to occur together simultaneously. Often this is used to describe the coexistence of both mental illness and a substance use disorder, and this is common among people in medication-assisted therapy, or MAT as we refer to it. Comorbid is generally used in medical settings and is the simultaneous presence of two or more diseases or medical conditions in a patient. Pharmacotherapy is the treatment of a disorder or disease with medication. In the treatment of addiction, medications are used to reduce the intensity of withdrawal symptoms, reduce alcohol and other drug cravings, and reduce the likelihood of use or relapse for specific drugs by blocking their effect. Medication-assisted therapy, formerly referred to as medication-assisted treatment, is the use of medications in combination with counseling and behavioral therapies, which is effective in the treatment of opioid use disorders, or OUD, and can help some people to sustain recovery. Substance use disorder is a mental disorder that affects a person's brain and behavior, leading to the person's inability to control their use of substances such as legal or illegal drugs, alcohol, or medications. Opioid use disorder is the inability to control use or reliance upon opioids, and these can be prescribed or off-the-street opioids. The terms coordinated, integrated, collaborative, co-located, and care or case management are often used interchangeably and can lead to confusion regarding the types of services that are being delivered, evaluated, or discussed. Collaborated care is not a fixed model or a specific approach. It is a concept that emphasizes opportunities to improve both accessibility and delivery of behavioral health and substance use services in primary care or healthcare settings through interdisciplinary or multidisciplinary collaboration. Models of collaborative care fall on a continuum. They're collaborations between primary care providers and behavioral health providers who work in separate systems and facilities and deliver separate care, and likely are using separate EHRs and other systems of working. In the middle of the continuum is on-site collaboration, or what is referred to as a co-located model. In co-located models, behavioral health and substance use providers and primary care providers deliver separate care in the same block of offices or in the same building. Also in the middle of the continuum is the care or case management, which involves assessing, planning, facilitating, and advocacy to meet the needs of the patient or client. On the other end of the collaborative care continuum is the integrated care model. We're going to be talking about this quite a bit today. In this model, primary care providers and behavioral health and substance use providers work together in a shared system, including shared treatment plans and medical records. Optimized integrated care models involve attention to mission, operations, information, financial and resource integration, while other team members stay within discipline or what we call scope of practice. Integrated care provides the best opportunity to reach the greatest number and variety of patients with evidence-based interventions. So from Jen and my standpoint today, we're going to be talking about what we do at Heritage Health, which is largely an integrated health system. In some of our clinics, we do share locations, in some we don't. As some of you may or may not know, Heritage Health has clinic sites in Rathdrum, in St. Mary's, in Kellogg, in Post Falls, and in Coeur d'Alene. So being co-located isn't physically possible for us just due to the number of clinics that we have. But we do have integrated care in that we share treatment plans and share with each other what the interventions are in coordinating that care. So when patients present for treatment of a substance use disorder, there are often other health and mental health issues going on. Co-occurring disorders are common. Up to 56% of people with the most serious mental illnesses have a co-occurring substance use disorder within their lifetime. Yet most patients with co-occurring disorders receive treatment from different agencies or for their mental illness or substance use disorder only, if they receive any treatment of any kind. This kind of fragmented treatment often leads to poor outcomes. Patients with co-occurring disorder have a better chance of recovering from both disorders when they receive mental health and substance use treatment in an integrated model. Studies also show that consumers who receive care in systems in which mental health and substance use treatment were separate were often excluded from services in one system and told to return when the problem was under control. Those who received services in non-integrated systems of care also had difficulty making sense of this disparate message or messages about treatment and recovery. Consequently, the evidence demonstrated that consumers with co-occurring disorders in non-integrated systems of care have poor outcomes. That's right. Teamwork makes the dream work. That's why we say this. In the National Guidelines for Behavioral Health Crisis Care, a best practice toolkit put out by SAMHSA, it is noted that a comprehensive and integrated crisis network is the first line of defense in preventing tragedies of public and patient safety, civil rights, extraordinary and unacceptable loss of lives, and the waste of resources. Effective crisis care saves lives and dollars and requires a systemic approach. Teamwork is a viable approach to improving those health outcomes. There has been a great deal of research conducted on positive outcomes produced by integrating care and adopting a team approach for those with co-occurring disorders. In fact, for pregnant women with co-occurring disorders, the U.S. Centers for Disease Control and Prevention recommends a multidisciplinary approach incorporating maternity care, addiction treatment, behavioral health, health promotion, and education. Both the World Health Organization and the American College of Obstetricians and Gynecologists endorse a treatment model involving close collaboration across disciplines. A case report that examined a multidisciplinary approach to the treatment of co-occurring opioid use disorder and post-traumatic stress disorder in pregnancy. A review of 38 studies of substance use treatment for women found positive treatment outcomes associated with collaborative, multidisciplinary programs which provided services including child care, prenatal care, mental health treatment, women-only admissions, and a comprehensive treatment approach. The case report concluded that providers working with pregnant women with substance use disorders must work together across disciplines to overcome barriers and ensure access to comprehensive care. The development of strong consultative relationships, along with protocols for shared management, can help solve the critical problem of access to timely and effective treatment for pregnant women with co-occurring disorders. And we actually have such a program here in Kootenai County at Kootenai Health in the resident treatment program, residency. Solheim report that teamwork across disciplines and including community representatives is a viable approach to improving health outcomes. Furthermore, primary healthcare values, principles, and elements such as making healthcare accessible, reaching all members of a population, and focusing health promotion and disease prevention are often embedded in teamwork. In a qualitative study of multidisciplinary team functioning, Colombo and colleagues note the importance of establishing a common identity or vision that transcends the ideological differences among disciplines and service models. Cohen et al. Performed a content analysis on 17 interventions that aimed to enhance adherence to healthy behaviors in the primary care setting, and concluded that more versatile, multifaceted solutions involving new, innovative approaches, including multidisciplinary teams, are needed in order to integrate healthy behavior change into everyday primary care routines. The U.S. Department of Health and Human Services, Substance Abuse and Mental Health Services Administration Center for Mental Health Services published an evidence-based practice toolkit titled Building Your Program, Integrated Treatment for Co-occurring Disorders, and its authors summarized this. Integrated treatment for co-occurring disorders and evidence-based practice is one of the most effective service strategies available, demonstrating consistent positive outcomes for vulnerable populations, for this vulnerable population. So I know that research is a little bit dry, but this is how we produce those best practices based off of the evidence that we have. So I'm going to turn over to Jen, and she's going to talk about developing an effective multidisciplinary team for MAT services.
I'm Jennifer Romero. I work for Restored Paths Heritage Health. I'm a social worker and a drug and alcohol counselor. I'm part of Heritage Health in the substance abuse program. So Heritage Health MAT Services has been around since 2017. We started this multidisciplinary team in an effort to actually utilize a grant that had come forth that really wanted all members of the team to talk to each other and to wrap around these clients so that they wouldn't fall through the cracks. I've been in this field for over 20 years. I had a solo private practice for many years, and what I saw, as probably many of you see, is that people come, get treatment, leave. A few years later, come, get treatment, leave. We were missing kind of wrapping around that whole person, getting their medical needs met, getting their mental health needs met, their dental needs, whatever that is. This grant was great in that it really had us look at our system and how we could utilize all of the pieces that we have to come together to wrap around this client and make them successful. Hopefully that they would have some lifelong change. So the primary goal of a multidisciplinary system is to save you time. So we don't have enough time in the day, and some folks look at these teams as taking up too much time. If you have a well-running team, you should even have more time to get more patients into your services. So streamlining that process, being able to talk through those barriers and those misunderstandings beforehand to create this team is really going to save you a lot of time. Removing those barriers, increasing confidence in primary care clinicians to address M.ED. So addiction has gotten kind of a bad name with primary care providers. This enables them to have more confidence in prescribing the medications, have more confidence in other team members and other departments. Increasing the patient support by emphasizing and referring to behavioral health needs, making sure all of those things are wrapped around them, and decreasing the hospitalization and overdoses, of course, is the primary goal. As far as staffing, there's 4 or 5 critical people. Your PCP, who's trained in a MAT waiver and is committed to being part of a team. So all of these people I'm talking about have to be committed to being part of the team, or it's just not going to work. An MA or an RN that has the awareness of opiate addiction, awareness of the medications that are used in MAT, the side effects, and those are usually the folks that we have scheduled with the providers. If you limit it to 1 or 2 people as a point person, for example, Heritage Health has a staff of 300 people. That 1 or 2 people is really integral in getting those people seen. The coordinator, like Laura, BHCs in similar roles. She helps kind of keep us all in line, coordinates staffing, directs referrals or any questions that people that might be falling through the cracks. And then you need your co-occurring disorders team through substance use treatment. They're familiar with opiate use disorder. They're familiar with the medications used. They're utilizing evidence-based curriculums and groups, and we're talking about coping skills, relapse prevention, trauma-informed treatment, all of that kind of good stuff. So you have 4 or 5 people at the table that's going to be able to wrap around or talk about what other services are needed to wrap around this client. Addiction is not everyone's cup of tea, so you're going to want to make sure that the staff members that are chosen for that team, that they're aware of principles of addiction, accountability, they're just comfortable with that population. Not everyone is comfortable, not everybody has to be comfortable, but if you want this team to work, those folks need to be comfortable in this. The physician role. So one of the things that I've heard from physicians that have taken on MAT treatment is they like that there's one problem. There's one problem to talk about, and that is the medication. Whereas if you're in a PCP role, then you've got the list of complaints of how I'm not feeling good today. So the MAT appointments are very structured and kind of one purpose. And that is sometimes relieving to PCPs that have run the gamut that day on all of the stuff that they've been talking about. So the induction to buprenorphine is usually a 40-minute visit, full exam, review the MAT contract. So the MAT contract can include that they are only going to one doctor, that they have to limit their ER visits. There's all kinds of pain contracts out there that you can Google. Patient signs a release for the substance use provider. So even though Heritage Health were in the same facility, substance use treatment providers that you would work with fall under CFR 42. So we just need additional language to help protect that patient. They submit to a urine sample, and medical staff runs the pharmacy report to see if they are kind of doctor shopping, where they're getting medications. And part of their MAT contract is to kind of narrow that down into one person providing all those medications, at least for medication-assisted treatment. Follow-up visits within 2 days, unless previously prescribed and they've tolerated it. Once the client is following through with resources like treatment and UAs, and the UAs are remarkable, then they'll drop that down to monthly. So there's all kinds of wiggle room in that. You'll probably be hearing a presentation from Dr. Realcrest about how all of that works, and so he can give you more kind of the meat and bones on that. The next staff member that you're going to have is the coordinator or the BHC. This person's going to has to have working knowledge of opiate use disorder, medications used to treat, side effects sometimes, and the relationships with all of the other relevant departments that you're looking for. It doesn't have to be a BHC. It could be one of the MAs or one of the substance use folks. The BHC was just a natural person for us because they had an arm's reach to all of the different locations and all the different departments that we have. Ideally, you'd want a warm handoff to a substance use provider. There's lots of myths and fallacies of what substance use providers look like, what treatment looks like, what groups look like some bad 70s movie or something. So having them be able to do a warm handoff and know that we're just normal people trying to help folks out. This coordinator also can create a formal referral. So important note, Healthy Connections. You don't need a Healthy Connections referral to refer to mental health services or substance use treatment services. So you won't have to go through that particular paperwork if you're looking at Medicaid. And this coordinator is committed to bringing the team together. So there's always going to be times when someone can't make it, and to get some kind of a staffing report or to get a time and a place that remind people that this is important, you have to come to this meeting, this is we're going to reschedule it because you're going to be there. So making sure that that person is there. Your co-occurring mental health and substance use treat providers, you want master's level clinicians capable of co-occurring disorders, working knowledge of the opiate use disorder, and awareness of medications used and side effects. And so sometimes they will, clients are in between provider visits for medication, maybe 2 or 3 weeks out, and they're having some kind of side effect, whether it's headaches or constipation, or they're starting to get cravings. That kind of information is helpful, so then we can either email or have the client talk to their provider to talk about what the medications are doing and either increasing or decreasing that. We're providing an assessment for substance use and mental health issues. That assessment usually drives what kind of treatment that person is going to do. They're going to be assigned groups, primary counselors, sometimes they're in case management. There's an opportunity right now to have housing paid for a bit, and also assign a drug testing facility. Even though your PCPs will do a drug test at the time that they're doing their medication appointment, it's important that your drug treatment provider, as far as substance use, when they're doing groups and individuals, that they're also drug testing that client to make sure that there's no illegal illicit substances or alcohol use. Ideally, at least 2 times a week. Most substance use disorders treatment takes between 3 and 12 months, depending on the client's issues, trauma, relapses, all of that kind of stuff. We also have Narcan kits that we give for free to those people, to those folks. We have them watch a 5-minute video about how to administer Narcan, how to visually see someone that's going into withdrawal, and when to provide that Narcan kit. They can get as many Narcan kits as they want as long as they watch the video. We only ask that they tell us if they use that Narcan and kind of what happened with that. Monthly staffing. So this is where all of it comes together. So once a month, the physicians, the MA or the RN, the BHC, and your co-occurring treatment staff come together for an hour. So there's a lot to do in that hour. So we're addressing any problems that the client has. So let's say that they've relapsed, or they've lost housing, or it looks like maybe they're diverting their medication because the medication isn't in their urine screen. So talking about all those kinds of folks, special dedication dedicated to those that aren't in compliance like we talked about, addressing any problems with getting clients into care. So for some reason they are getting the runaround because they didn't call your particular MA or RN to get that appointment with the MAT provider. So making sure that you're problem solving all those process questions. Discussing further referrals. So do they really need to go to psych? Do they need to go to maybe St. Vincent's or the Medicaid food stamps or those kinds of things for needs? We also email physicians and treatment providers back and forth in between the monthly staffings if stuff that is significant happens, like there are relapses or there's life changes, losing their job, housing. This was critical in the COVID era where like nobody was in the office to be able to email about all of those things. Those folks really struggled with not having in-person appointments. There's also needs to be, in your process of creating this team, no wrong door to accessing treatment. So there's generally two routes to access treatment. One is that they have found somehow a physician that can prescribe MAT. That physician, at least in our team, then refers them out for a substance use treatment, right? A pill doesn't solve everything. We've got to have some skills behind it. We then schedule them for assessment, determine their level of care and what groups and counselor they're going to have, and then email the physician back so he has all of the information. We also email the physician if they don't show up so that the physician can hold them accountable. That physician needs to meet with the MAT team monthly and emails the team members with significant issues. Route two, they present to us, the treatment provider in our facility. They complete our assessment. We are aware that they have a opiate use disorder. Some people don't know about medication-assisted treatment. We talk to them about that, see if that's something they want to do. If we do, then we're able to contact the MA or the RN to schedule those appointments, and then they'll meet with the MAT provider, hopefully within a week or two, and then email the team with any issues, do their assessment, and they'll be on the staffing roster for the monthly staff meetings. So here's the benefits. Here's why you want to do this. You want to create a team that wraps around the patient. So if we have a need, that's what I found when I was a solo practitioner, is that I would treat one slice of their life, their substance use section, but I wouldn't be able to follow up on, did they get their mental health needs met? Did they get their medical needs met? Did they get their just human needs met? House, job, transportation, food. This way, we're wrapping around the client and making sure that there's no rock that's left unturned. We're also taking the pressure off of primary care clinicians to manage the addiction treatment on their own. So MAT treatment can be a little scary, can be a little, when you don't have a lot of experience with that. We have newer physicians with older physicians on our MAT monthly meetings. They're able to ask questions and bounce back and forth. For example, what happens if a client relapses when they're on medication-assisted treatment? You're able to bounce that off lots of people instead of having the pressure to take that on yourself. You help expand access to care to more patients. A well-functioning team can help frequent people from coming in over and over and over again, or clogging up your MA with questions where that's something they can ask treatment, or that's something that we can do a quick email instead of taking up a 20-minute spot on your schedule. asking questions to other PCPs regarding med adjustments. We just talked about that. Hopefully through all of this, we're going to decrease overdoses. We're going to decrease hospitalization. We want to improve, of course, the overall health of our patients and referrals to further providers or specialists. We all come with our bag of tricks of people that we know that can do stuff. The more people on this team, the more you're better able to benefit your clients. So here's our contact information. Laura Bonneville, who you saw before, and myself, Jen Romero. And please feel free to email us with any questions or contact us by phone. I think it's easier for both of us, given all the locations that Heritage Health has, to email us because we kind of have our phones attached to our hips. Thank you.